From the research bench to the patient's bedside, this is Bench to Bedside with your host, Vice Chancellor and Director of the University of Kansas Cancer Center, Dr. Roy Jensen.
Prostate cancer is the most common cancer and the second leading cause of cancer death among men in the United States. At the University of Kansas Cancer Center, we address prostate cancer across the cancer continuum. From the scientists in our labs to the doctors in our clinics and our partners in the community, we are tackling this disease from all angles. Good morning. I'm Dr. Roy Jensen, Vice Chancellor and Director of the University of Kansas Cancer Center. Here with me this morning is Dr. Will Parker, and Dr. Urologic Oncologist, and Dr. Xingli Shen, Radiation Oncologist. And Broderick Crawford is joining us as a member of PIVOT, our Patient Research Advocacy Program, and he is also the chair of our Community Advisory Board. Thank you for joining us this morning, Broderick.
Thank you for having me.
Broderick, could you start off and tell us about your experience with prostate cancer?
Absolutely, and thank you, Dr. Jensen, for allowing me to join you this morning. My prostate cancer experience began initially with my dad. We lost my dad January of last year, but my dad fought prostate cancer for 13 years. And so I was very involved with my dad going to different clinics. And I'm sure you guys remember the good Dr. John Weigel, who took care of my dad. And as you know, Dr. Weigel, he's quite the urologist. So yeah, we had a good time interacting with Dr. Weigel. But a couple of things that were striking is my dad did not get diagnosed until he was 77. And so at that point in his life, there were a lot of options and treatments that were no longer eligible for him because of his age and other underlying conditions that he had. I'll also share a story about my uncle who was in the Chicago area, who was also diagnosed late. He was diagnosed at 68. And where he was diagnosed, they did not even provide him any options. They did the wait and see. Well, when my uncle went to a different urologist, there was a total different plan where with the wait and see, his body began to deteriorate and he was not afforded quality of life. Once he moved to a different physician, a different urologist, then things began to get better. So both with my dad and my uncle, I have instances of African-American men who were diagnosed late in life. And perhaps if they would have been diagnosed earlier, their quality of life would have improved and their longevity of life could have been better.
Thanks for sharing that. Dr. Parker, how does the prostate cancer multidisciplinary clinic work? And what are the advantages of having multiple experts together working on a patient?
That's a great question, and I'd also like to express my thanks for having us here to talk about this. This is obviously a very important topic and things that need to be addressed. I think the most important thing, first off, is what is multidisciplinary care in prostate cancer, and it's really wrapping a group of physicians with a shared goal of prostate cancer treatment around a patient. And that may be different for different scenarios. It could just be Dr. Shen and myself as urologic oncologists and radiation oncologists are the primary treaters. It could be including a medical oncologist in that care as well. In terms of the advantage of that is it really does allow each of us to speak to our individual strengths and specialties offerings in terms of prostate cancer and allows a patient to have access to a little bit less biased care recommendations. I know that when I'm talking with a patient with Dr. Shin and we're together counseling somebody, they're getting a much more complete picture than when we're each individually doing the same.
Mm-hmm. So Dr. Shin, how does a patient access our multidisciplinary clinic?
So I think one of the really great advantages working like here for both myself, the provider, and the patients is our care navigation, nurse navigators. So you have prostate cancer, you don't need to know anything. You just give our navigators a call. They'll set this up. So that means, they'll track down all the records. They'll coordinate our appointments together, get everything ready, everything you need ready, and to go. And really, and that, oftentimes it's within a week, a few days, and we'll be seeing you.
So one of the latest features that we've brought on board in the last year or so is the telehealth second opinion. Could you tell us a little bit about how that works, Dr. Parker?
Absolutely. The telehealth multi-D clinic is really, I think, one of the key strengths of our prostate cancer program. So what it allows us to do is Dr. Shin and I have a visit with someone together. So we're in the room together as opposed to separating visits out across clinical spaces. It affords a person to have really pretty convenient access to cares. They can do it from their own couch, their own living room, and they get the access to both of us simultaneously in the room together and counseling them. To Dr. Shin's point, and I think this is the other piece of this, is that because of the nurse navigation program, we already have those records, and he and I have often already spoken about the clinical scenario, so we know the things that we're each keyed on and really focused on as part of that care journey.
Mm-hmm. If you're just joining us, we are here with Dr. Will Parker, Dr. Xingli Shen, and Mr. Broderick Crawford. We're going to have to give you an honorary doctorate, Broderick. You're over at the medical center so much. I just awarded it to you. And we're discussing the importance of a multidisciplinary approach to your prostate care. And remember to share this link with people you think might benefit from our discussion. Use the hashtag #BenchToBedside. So let's talk a little bit about prevention and a study that was published by someone that we all know very well, our very own Dr. Ronald Chen, who is chair of radiation oncology. And he found that nearly 10 million cancer screenings in the U.S. had failed to happen because of the COVID pandemic. And that study looked at 3 cancers in particular: breast, colorectal, and prostate. And so maybe if Dr. Parker, if you could tell us a little bit about why it is so important to get the recommended prostate cancer screenings.
Absolutely. So first off, we know screening for prostate cancer saves lives. The mortality from prostate cancer has gone down since the advent of PSA-based prostate cancer screening. And so it's vitally important that we screen to detect these cancers early. To Broderick's point about his individual experience with his family members, the earlier we can detect, the better the options are, the better the outcomes are, the less morbidity, and the better quality of life there are for people suffering from this disease.
Mm-hmm. So African American men in particular are 1.6 times more likely to get prostate cancer in their lifetimes, and more than twice as likely to die from it. And prostate cancer is highly treatable when caught early, as we've already mentioned. And Broderick, in your role as the chair of our community advisory board, how would you say that the board supports our efforts to engage with various constituencies in our community and get the word out about the importance of regular cancer screenings?
Absolutely. Thank you, Dr. Jensen, for that question. I am honored and privileged to serve as the inaugural chair of our KU Cancer Center's Community Advisory Board. And a few things that we try to do: one, understand what our cancer center's catchment area is, because we want to understand, as we identify our catchment area, then the disparities and inequities that exist within our catchment area. We want to be able to engage with men and women, with families throughout our catchment area. And then once we are engaging with them, we want to take that information and then bring it back to our cancer center. So what may be happening in, let's say, Pittsburgh, Kansas versus Kansas City, Kansas versus Wichita versus Emporia, we want to be able to understand the experiences that these men have, whether it's in a rural, urban, or even suburban area. And then we want to assist with developing the strategy. So once we understand the disparities and the inequities, then we need to develop a plan. So once we then identify what those disparities are, develop our plan, then we want to make sure that the plan is not only implemented, but if there are times when we need to adjust the plan, we can do so. If there are times when we need to alter a particular pathway, we can do so. So it's very important for our board members to be the eyes and ears, the boots on the ground for the Cancer Center throughout our catchment area so that we can best serve the residents, the patients that we have within the KU Cancer Center catchment area.
Well, we certainly appreciate your role in helping us get out that message, Broderick. You know, as our audience is well aware, one of the most important things we do at the KU Cancer Center is to conduct clinical trials. And I would love to hear from you. What do you think are the barriers that minorities and other underserved populations face when it comes to participating in clinical trials?
Absolutely. Again, thank you, Dr. Jensen, for that question. And in many cases, we understand that one of the key factors is trust. And so, you know, we can go back to the numerous times when researchers have not treated minority populations in a fair and equitable way. We now understand that because of that trust, even though some of these things that have happened were many years ago, it still resonates with the community today. I would also submit to you that there is a lack of understanding physician to patient. And what do I mean by that? If I understand and I have a relationship with you, Dr. Jensen, then I'm going to be more likely to trust you when you offer me the opportunity to participate in a clinical trial. If there is no patient to physician relationship, then that's going to decrease the opportunity for that to happen. And the other thing that I'll mention is how frequently do our cancer oncologists even offer to minority patients the opportunity to participate in clinical trials? I would submit to you that when you look at the number of individuals who participate and the number of individuals who are even offered to participate, there's a disparity. And then finally, the thing that I think many of our minority men don't understand is the value of a clinical trial. In many cases, a clinical trial could be producing that life-saving drug or that life-saving treatment for them while they're participating. Without participating in that clinical trial, that doesn't happen. And so those are areas that I try to engage, again, with men, as we say, BIPOC individuals within our community and within our catchment area.
So, Broderick, you and I have talked about this on a number of occasions. Why is it so important that we bring diversity to our clinical trial participants?
Absolutely, and thank you again. It is critically important for us to move the needle as it relates to developing and eradicating or providing treatments and drugs for our men of color. Diversity is important because, as you all each know, the same treatment is not going to work for each individual, even within a specific race or ethnicity. So we can't expect what would work with one particular race or population to work in all. It just doesn't work that way. We can certainly have evidence to say there's a good chance, but without diversity in clinical trials, we never necessarily know for sure. And so what we want to do is to have the same level of evidence, the same level of effectiveness, the same level of participation with men of color in clinical trials, being able to speak through and work through the four topics or the 4 points that I just made previously. It is critically important for us to have men participating, men of color participating in clinical trials.
Great point, Broderick. And now I think our audience knows why we asked Broderick to serve in these roles in the Cancer Center. So, Dr. Shin, what are the advantages for patients, and specifically prostate cancer patients, to seek care in an NCI designated cancer center like the University of Kansas Cancer Center?
No, thank you, Dr. Johnson. That is a really important point. And it's one of the things like I think it's not always obvious, but I think there's two parts to that answer. I think one for me is the people. Like you have people who are like Dr. Parker, myself, experts that all Dr. Parker does is prostate surgery. You know, we have some other physicians, Dr. Parikh, Dr. Wolf Birchfield. All they do is, to give oncology services, chemotherapy, hormone therapy for prostate cancer patients. Very specialized, but also very accessible. You know, if I need help, like as a radiation oncologist, if I need help with something, I can call up Dr. Parker and call Dr. Wolf Birchfield, Dr. Parikh, and they're available to provide this multidisciplinary care immediately. It's this cooperation, and I don't want to mean just the cancer providers, but also our radiologists, our pathologists. We all work together and have access to each other very rapidly. The second part of that is to being up to date on the most advanced treatments. So we all participate in national conferences, we all present in national conferences, so we know what's going on in the national scene as well as local scene. And part of knowing what's going on is to be able to provide the most up-to-date clinical trials, right? We have multiple clinical trials open in the prostate cancer space, from early stage trials or even active surveillance. Dr. Parker is just opening a trial right now looking at how can we use some very common chemicals to make active surveillance more successful, all the way to very late phase trials. We're looking at patients who've progressed through multiple lines of treatment, and we're looking at some newer agents to kind of give a shot at find new ways to control these cancers from the very beginning all the way to the very end. And not only do we have these trials available for patients, we also know what's coming up, in terms of future trials. Like, people read about different things in the news, and you can say, well, yeah, that's going to be available in a few months, or, well, it's kind of a concept, we're trying to work on it, but it's not quite there yet. So not only having the trials available for patients, but also knowing what's coming down the line, what's exciting, and what's going to happen.
So, Dr. Shen, speaking of cutting-edge therapeutic approaches, what is the latest on our new proton therapy center?
Well, it's obviously very exciting for us. So, we do not have a proton facility in Kansas City right now, but our facility is going to be the first one in Kansas City area. We're slated to open and start treating our first patient probably around April. So that's less than 6 months away, or 6 months away. It's going to be very exciting for our patients. It's a new modality. It is not just, I think some patients think of it as being more precise than regular radiation, and it's not quite that. It's actually biologically a different treatment. It allows us to spare certain tissues and to have less side effects, but it also allows us to do some treatments that you just can't do with regular photon X-ray radiation. Opens up avenues for research, but also just standard of care treatments. It's actually a better treatment for many of our patients.
Mm-hmm. So I think you've already started answering this question, but why is it so important that the University of Kansas Cancer Center will be able to provide proton therapy to our patients, not just prostate cancer patients, but an entire range of folks?
So, I mean, this is a technology we need to have. For a while, for instance, I was helped out with treating some of our pediatric patients. And, in order to get proton services, some of our folks were driving, or leaving their work for, 6-8 weeks at a time, completely displacing themselves from Kansas City area to go somewhere to get protons. And that's not right. We need to be able to provide some of these services to the people of this area. It's our mission as a hospital, I think, to provide the best care here. Protons, it's not just radiation. It's a way to give radiation to avoid giving extra dose to the tissues, very sensitive tissues around the target area. it provides a definitively better treatment for certain cancers. And prostate cancer is one of them. We have critical organs around the prostate, obviously, and so it is possible to reduce side effects with protons. But to your point, Dr. Jensen, it's incredibly important for certain other cancers where you just simply cannot get even close to how good an outcome you can with protons as with regular X-rays. So I think we do a pretty good job, with regular X-rays for prostate cancer patients, but for some of our pediatric patients or some re-irradiation patients, you just cannot replicate the proton experience.
So Broderick, as you mentioned earlier, your journey as a caregiver really began about 15 years ago with your father. What do you know now that you wish you had known back then? And what advice do you have for other caregivers that are just beginning their journey down that path?
Thank you again for the opportunity, Dr. Jensen. First thing that I would say is access. And access not just for myself, but also my mom, my brothers, my sister, access that we all have to participate in the care and the treatment plan for our loved one. As you also know, I have the pleasure of serving as a member of the National Advisory Board through the Recruitment Innovation Center out of Vanderbilt University and Meharry Medical College. The number of other opportunities that are out there that we would have no idea of. And it's only through the work that I've been able to do with the RIC that allows us to have further understanding, greater understanding of prostate cancer, and then the opportunities, whether they be clinical trials, whether they be treatment plans. In some cases, my dad unfortunately had to deal with ED. And so how do we have that conversation? How do we be able to talk about it in a constructive way to be able to not only satisfy the person who has prostate cancer, but then also the family members? And then finally, the thing that I would say is just access to excellent physicians like the three of you. Early on, my dad was initially diagnosed. We didn't know to ask questions of a urologic oncologist. We didn't know to ask questions of a radiation oncologist. And again, because my dad was diagnosed late in life, many of those options were limited. And so the thing that I would definitely share, and if I will preach to folks who are caregivers, is get tested, get screened. It is so important for folks to get screened early so that quality of life can be maintained throughout their later years.
So as we come to the close of our program, I'd like to hear from really all of you about what about the future of prostate cancer treatment and prevention excites each of you the most. And Broderick, maybe we'll start with you.
Thank you so much, Dr. Jensen, and thank you, Dr. Parker and Dr. Shin, for allowing me to participate with you all with this very important subject today. The future, I would say, is very bright. We have a number of caregivers and support groups that rally around our prostate cancer survivors. I think we now have the opportunity to really shed a light on the importance of getting screened early, because if you are screened and detected early, the treatment is very, very positive. So although it is one of the leading causes of cancer and deaths in African American men, it can be treated when caught early. So I am just excited about the new treatments that are coming along. As again, Dr. Shin was talking about the proton therapy. Those types of things excite us, and we want to make sure that not only we're on the ground floor, making sure that we're providing access to our fellow prostate cancer survivors, but also making sure that the families understand what's available to them.
Dr. Shen?
Yeah, well, I want to echo Broderick's point about it's a very exciting and optimistic time right now. There's so many things on the horizon, in terms of treatment and diagnosis. A couple of things I want to highlight is the PSMA. A lot of prostate cancer survivors know about this, but it's a newer molecule that allows us to see prostate cancers more effectively in the body. We can see them and we can target them with conventional treatments, or we can tag a killer molecule onto that and target the prostate cancer anywhere in the body. So I think, and I use that as an example. I think we're developing more and more treatments. If you look at the number of drugs that have been approved for prostate cancer in the last 3 years, it's just exponentially increasing. And so we're just finding more and more better things. But I think what really excites me about where things are right now in the next couple of years is we're moving more and more into the genomic world. And this, I know, our cancer center and others too do a lot of work in this, and it can help make this happen. But right now we're not just looking at a prostate cancer like you have prostate cancer. We're looking at prostate cancer like, well, you have prostate cancer with these mutations and these alterations, and we're gonna treat you differently based on all the different things that are specific to your particular prostate cancer. This idea of personalized medicine, but we're really getting to the point where we can actually do something about it. And so we have some trials coming up, for instance, where we're getting genomic profiling of cancers and then stratifying or altering treatments to be more aggressive or less aggressive depending on what the genomic profile looks like. I think in the future, things like that will help provide the right treatment, the right amount of treatment for our patients.
Great. And Dr. Parker?
Yeah, so, prostate cancer is this huge disease. There's a big spectrum from men at the screening stage to men at the end of their journey. And as we've talked about, this is exciting. There's been an explosion of treatments available at multiple places in this disease. But one area where there has been this new and renewed push is in the idea of focal therapy. So currently in localized disease, we treat prostate cancer as either something that doesn't need to be treated or something that needs a radical treatment that has a fair amount of morbidity and side effects and quality of life impacting effects. Focal therapy offers, for some men, a potential to reduce those side effects but yet still offer cure. And so that, to me, is where the field is likely going to be moving and where I'm the most excited right now.
Yeah. It's all very exciting, and I'm sorry I didn't get the bow tie memo today, but I'll try to do better next time. And that's it for today. Thank you for joining us. To learn more about prostate cancer, visit kucancercenter.org/prostate. Join us next week at 10 a.m. for Bench to Bedside. Thanks for watching. Subscribe to our Bench to Bedside podcast, now everywhere podcasts are available.